Hello, my name is Tiffany. This presentation is for societal health and healthcare systems, and I'm going to be discussing an overview of social determinants of health in the context of physical therapy using a few examples from research. Okay, so on this slide, this is a quick overview of the Kaiser Family Foundation model, which outlines the social determinants of health. So we understand these to be the different factors and circumstances that affect health outcomes as well as affect populations' access to health care. So this includes economic stability, including employment status, housing status. The second point is neighborhood and physical environment. So whether or not a person lives in a food desert, whether or not they live close by to a hospital, if they have regular access to dentistry or primary care, whether they can access a pharmacy easily. The third point is education level. So this includes whether or not a person has finished high school, has received a diploma, and whether or not they have been able to pursue any form of higher education, whether community college or university degree. And of course, education level affects career outcomes as well as insurance coverage. Community and social context. This has more to do with the cultural components such as racial groups and cultural identities, and as well as language barriers that might affect a person's access to healthcare. The last point, healthcare access and quality, is more of a general category that includes other factors that also affect a person's ability to access healthcare and to see their primary care provider or even to access surgery. So this might include transportation, it might include insurance coverage, as well as copays, financials, and even policies, as well as direct access versus referrals. Okay, this slide is just a quick overview which gives the difference between health conditions and clinical outcomes. So I'm kind of using this model when I discuss the studies. So I was interested in this kind of area of research which focused on total joint replacement surgeries, that whether that's knee replacement, hip replacement. So I was looking into studies that discussed the social determinants of health in the context of access to joint replacement surgeries. So here's some bullet points from the 3 different studies I looked into, which has to do with economic stability. So it was shown that patients with lower income who have Medicaid insurance had lower utilization overall of total joint procedures. Lower income brackets and insurance types were also associated with worse post-operative outcomes following surgeries and rehab. And this was interesting. In Australia, the condition of osteoarthritis was found to be a significant economic burden across the country. In 2019, they spent $3.9 billion managing OA, and $2.3 billion was spent on knee and hip replacement surgeries. And these costs are expected to rise over time as the population is aging. Limiting access to these procedures by preset criteria could just make health disparities worse. All right, in this slide, I'm going to be discussing the neighborhood and physical environment aspect of the social determinants of health. So in certain studies, they grouped participants and surgical candidates based on higher and lower economic status to assess their risk for undergoing surgery. And basically, it was found that people who were in higher levels of socioeconomic status were more likely to receive joint replacement surgery, and those in lower status underwent the surgery less often. And this study used an index of relative socioeconomic disadvantage, which is a statistical, basically, determination. A report from 2025 in Australia showed that 60 to 70% of these procedures, specifically for joint replacement, were performed in private hospitals, and these were disproportionately among the high economic status individuals. So this association between the high economic status and access to surgery shows that the affordability and access to private surgery is not so much a biological risk factor, but it's an economic factor. And disadvantaged communities were thereby underserviced and left with a significant burden of unmet surgical needs. So for the clinical outcome, policy level investigations into healthcare equity and underserviced groups are basically warranted based on these outcomes, and reducing barriers across communities in these various groups would support more equitable joint replacement access. Okay, for education, again, a similar trend as with the higher economic status, higher levels of education correlated with more frequent surgeries, whereas groups that were more socially vulnerable, they had higher levels of vulnerability, they received lower numbers of the joint replacement surgeries. So this domain of socioeconomic vulnerability combines various measures including poverty, employment, per capita income, and whether or not a person has a high school diploma. And in areas where there are a higher concentration of Medicare, Medicaid patients, there was a lower documented availability of surgeons who would accept those patients. So one study was arguing that a multi-sectoral approach is needed to build better community infrastructure that promotes access to resources and to improve overall health outcomes to address these inequities. As far as community and social context, clearly there are racial and ethnic disparities at work here, and it's been documented, for example, by the orthopedic community, that there are clear differences in the receipt of these surgeries based on racial and ethnic groups. For example, Asian, Black, and Hispanic individuals had lower odds, 26 to 41% lower odds of receiving total joint replacement compared with white people. And this could be explained due to structural racism, interpersonal bias, discrimination, and also disparities result due to patients who do not speak English as their primary language, as this is a barrier to accessing healthcare and to pursuing surgery. Again, people who were enrolled in Medicare who had arthritis, living in counties which experienced high vulnerability scores, received fewer surgeries compared with those in lower vulnerability areas. So the bottom line, the outcome here is that addressing social and structural factors affecting surgical access requires collaboration across many fields and professionals, including healthcare providers, insurance companies, community organizers, and government at all levels. So the last social determinant we will discuss here is healthcare access and quality. Just to underscore the previous points, the patients who had Medicare and Medicaid enrollment had 60% less surgeries documented that were completed. And this could be due to just the payment and insurance models. So providers, they generally receive lower reimbursements for providing services to Medicaid patients, and they also experience long delays in receiving these payments. So because of these financial pressures, many surgeons, they limit the number of Medicaid patients whom they accept to their practice. So this creates a disparity and sort of a bottleneck effect where there are many patients left waiting who are underserved. And another important factor to consider would be medical comorbidities. So minority groups and highly vulnerable populations are reported to have higher rates of these comorbidities, including diabetes, dental issues, anemia, and obesity, as well as a higher risk of postoperative complications. And because of these complications, they are often disqualified from even being eligible to receive total joint replacement surgeries. And due to being disqualified and not meeting the cutoffs, this exacerbates the racial and social disparities that exist and just further increases the number of people who are not accessing the care that they need. So one particular study tried to implement this kind of quality initiative in an optimization procedure as a method to screen patients for eligibility. But they found in their study that standard optimization failed to improve outcomes for inner city and underserved populations. So the researchers were arguing that what's needed is the development of population-specific models to guide outcomes and reimbursement structures. And this is needed to improve access to healthcare by taking into account social and racial disparities which are affecting communities in diverse levels of socioeconomic resources and various social strata. Here is just a quick summary of the references that were used. As I mentioned, one of the studies came from Australia. The first study here focused on hip and knee joint replacement among underserved populations. The second studied key determinants for lowering the risks involved in taking on and becoming eligible for surgeries. And then the last paper focused on the Medicare and insurance side of receiving surgery for patients who have arthritis. Thank you so much.